Hello again. Welcome to the second part of my three-part series on Introduction to Oculus Regenerus Eye Care Research Center. I'm the founder and director, and today we are going to talk on treatment of corneal scars and keratolimbal allografts. Now, the human cornea is a tough connective tissue which acts as a barrier between the eye and the outside world. It's a transparent structure. It provides almost two-thirds of the power of the eye and is essential for focusing light on the retina. Now, 90% of corneal volume is stroma. This is a collagenous mesenchymal tissue. It is comprised of multiple tightly packed lamellae. These collagen fibrils are very small and very uniform in diameter, and the orderly packing of these lamellae is essential to keep it transparent. Now, if there is a surgery or a trauma or bacterial or fungal infection, a scarring of the corneal stroma can happen. Now, the cells responsible for scar formation are fibroblastic cells, which are derived from the stromal keratocytes. Now, corneal scars are very long lasting and they disrupt the vision for millions all over the world. So currently, what we do is surgical replacement of the cornea. This is done by the partial thickness or full thickness corneal transplantation, which is a type of organ transplantation. Thus far, this has very good success rates as compared to other organs. However, it is not without its problems. Corneal graft rejections, corneal infections, glaucoma, all these are very commonly associated with corneal transplant, and the average life of a cornea with a very good prognosis is not more than 10 to 15 years. Scars associated with either blood vessels or with neurotrophy pose an even greater challenge to corneal specialists. Now, today I am going to talk about 3 cases with dense scars which were treated with a simple procedure. Now, the first case was a 37-year-old male with history of excision of a CP angle tumor. He had lack of thalamus, corneal neurotrophy, which was treated with tarsorrhaphy, and despite all these measures, he had an infection which resulted in the formation of a macular grade scar. And the scar had been stable for the past 6 months on our follow-up, and the patient wanted treatment for the same. Second was a 60-year-old female with a history of injury with a tree branch. This resulted in formation of a nebulomacular grade scar. Patient had defective vision in both eyes and was afraid to undergo any surgical procedure even in the other eye, which suffered from a simple cataract. Third case is again of a young male, 47-year-old, who had burnt out herpes stromal keratitis. He had been again on stable follow-up with us for the past 1 year or so, with no recurrences whatsoever. Before I go into the depths of what we did and why we did it, let's take a step back and look at what happens to the cornea when it is wounded. Normally, keratocytes are a population of quiescent cells. These are derived from the neural crest and they are present sitting between the lamellae, and they are responsible for secretion of a unique stromal extracellular matrix. These quiescent cells hardly ever replicate, but in response to an injury, what happens is they become mitotic and adopt a fibroblastic phenotype. This activation results in deposition of new extracellular matrix with the composition and light transmission properties that are different from the normal cornea. Such uninjured stroma is actually transparent, whereas new collagen deposited by the injured keratocytes activated thus is not so. Thus deposited corneal scars remain for decades in the cornea. So let's take a step back and look at what's happening in the field of regenerative medicine. Patients with diseased or injured organs who are treated with transplanted organs suffer from a major shortage of donor organs, say kidney or heart or any other. Now this shortage worsens as the population ages because the number of new cases of organ failure is also increasing. Now, scientists in the field of regenerative medicine and tissue engineering are applying the principles of cell transplantation material sciences, bioengineering, among other things, to construct biological substitutes. Now, these should be able to restore and maintain function of diseased or injured tissues, thus bypassing organ transplantation in at least some ways. Stem cell field is a rapidly advancing part of regenerative medicine, and new discoveries in this field are creating options for such type of therapy. However, stem cell therapy is not without its problems. Thus far, the only stem cells that are being used or approved for use in patients are hematopoietic stem cells. Thus, stem cell therapy, either mesenchymal or of any other form, is still in research phase and will take some time to come for the utilization of the masses. However, some therapies as part of regenerative medicine make use of autologous adult cells, not stem cells, and these have already entered the clinical setting. Bladders have been made, ear lobes have been constructed, decellularized liver scaffolds have been repopulated, all with the use of adult cells and not stem cells. Now, what is the aim of regenerative medicine? So, what we are trying to do is dysfunctional tissue that is present is to be replaced by healthy tissue. Now, we don't just want to resurrect normal anatomy, but also normal physiology. And we want to replace dysfunctional tissue with functional one at cellular, subcellular, and genetic levels. Now, how do we control tissue morphogenesis? So there are two ways. Either you give new cells altogether. So we are ruling that out. The other aspect would be to deliver crucial signals to either the resident multipotent cells or to infiltrating multipotent cells, that is through the blood. This is called as in situ corneal or tissue regeneration. Now, what's happening in situ tissue regeneration is that we utilize the host responses to a target specific scaffold. This mobilizes host cells to the site of injury without actual need of cell seeding. Now, this would be fantastic because we wouldn't be using anybody else's cells. Now, Dr. Atala's group from Wake Forest Institute of Regenerative Medicine have successfully shown that tissue morphogenesis can be controlled by delivering crucial signals either to the infiltrating multipotent cells or the resident cells, forming functional tissues in situ. This is against conventional cell-based strategies. So what have they done so far? So Lee et al., one of their authors, showed that recruitment of host renal stem cell or progenitor cells can happen in an injured kidney model. So he showed this that this can happen in an animal model by facilitating anatomical and physiological recovery, and he attributed it to combination of host response to injury and to injection of a collagen hydrogel that was injected into the animal kidney. This actually promoted repair of the cells, reduced their cell death, and decreased post-injury glomerular loss. Now this is fantastic because the only treatment is now either dialysis or kidney transplantation. Other studies have also demonstrated such recruitment in plants and in skeletal muscles. So let's now come back to the cornea. So what do we know about corneal regeneration in situ? Now, constant source of epithelial cells is believed and proven to be the limbus. And corneal epithelial stem cells have been identified deep within a protected microenvironment called the limbal niche, which is present called the limbal palisades of Vogt. When the limbus is damaged, either because of injury or inflammation, the normal corneal epithelial physiological features are disrupted. So delay or failure of corneal epithelialization would lead to a conjunctival encroachment over the cornea, vascularization, non-healing epithelial defects. All these are called as limbal stem cell deficiency. Now, identification of stem cells from the corneal stroma was also achieved. So we've spoken about the corneal epithelial stem cells which are present in the limbal niche. Now I'm coming to corneal stromal stem cells. So corneal stromal stem cells have been shown to be present either in the limbal pallidus or in this resident in this corneal stroma. So they were identified by population of cells that efflux the DNA binding host 33342, and they were termed as the corneal stromal stem cells. They have been shown to we have been able to grow them in the lab up to 100 cumulative population doublings. So post corneal transplants, stromal cells that are derived from the host have been identified in the grafted tissue, which indicates that keratocytes can repopulate stromal tissue without actually scarring. So such repopulation of keratocytes or stromal stem cells is very slow and sometimes probably requiring decades. And we don't actually say keratocytes are terminally differentiated because they don't conform to the classic definition of these cells. But some cells in the stroma do maintain the capability to replicate and regenerate transparent corneal tissue. Now, another interesting experiment in which scientists showed that when corneal epithelial stem cells are from the limbus are isolated and attempted to be cultured, if they are co-cultured in the presence of mesenchymal cells present right there at the limbus, then they grow much better. So these corneal stromal stem cells present at the limbus express genes which are common with mesenchymal stem cells present elsewhere in the body. So all mesenchymal cells have the same kind of identifiers or markers that we call. So CD105, 6, 54, 166. These are all common identifiers for mesenchymal stem cells. These are present both in the stromal stem cells present at the limbus and within the host stroma or within the human stroma. Now, our scientists are no far behind systemic. So, Dr. Funderburg's group actually showed that in the mouse model, corneal opacity could be reversed, and that cultured corneal stromal stem cells express genes very similar to resident corneal stromal stem cells. So he's done a lot of the animal work and has established that corneal stromal stem cells can actually reverse a scar in animal models. Now, in 2012, Angunawala and Liu et al. Placed corneal lenticule in a stromal packet in rabbits and showed restoration of corneal clarity. Now, so far this has all been in animals. In 2016, Dr. Sangwan's group serendipitously reported observation of progressively resolution of corneal scars in their cases of chemical injury with limbal stem cell deficiency, which had been treated with SLET. Again in 2017, Dr. Geeta Iyer's group from Shankar Nethralaya utilized allogenic simple limbal transplantation in acute ocular injury. They showed that none of the eyes in which they had used such limbal tissue had developed stromal scarring sufficient to warrant keratoplasty. Now, what is SLET actually? Now, SLET was described in 2012 by Dr. Sangwan. It allows repair of damaged ocular surface in uniocular cases of limbal stem cell deficiency. Now, typically it has been used in cases of limbal stem cell deficiency. It addresses two problems: large donor contribution requirement and expense by taking small amount of tissue and expanding the cells in vivo on amniotic membrane. Simple limbal transplantation has been subjected to intense scientific scrutiny. It has managed to emerge as an effective, safe and reliable surgical technique for treatment of ocular diseases due to stem cell deficiency. So what did we do in these cases? First thing we assured was the absence of stem cell deficiency in the ipsilateral eye. under topical anesthesia, 3 millimeters of the limbus was excised from the healthy eye at the superior limbus. The limbal bits were then kept aside. The recipient site was prepared by debridement of the epithelium around the scar. Healthy corneal epithelium was left undisturbed. The recipient cornea was then covered with the amniotic membrane and glued with the use of fibrin glue. The chips that had been cut were then transplanted onto the surface of the amniotic membrane, and they were evenly distributed along the scars, more number and larger pieces being placed at the denser areas of the scars. Glue was once again applied and then a bandage contact lens was placed. So you can see that progressively we have resolution of the scar. So this first case we have a follow-up of up to 4 years, wherein you can see that the scar is almost progressive resolution of the scar has been maintained with maintenance of recovery of visual acuity for up to 4 years. Second case again has responded. However, the scar that has not completely disappeared or even significantly disappeared, I would say, but the part of the scar that was closer to the visual axis has faded off, and the patient has recovered at least 30 to 40% of her visual acuity. Third case again, up to the period of 8 months follow-up, has shown progressive resolution of the scar and has shown tremendous relief in improvement in visual acuity. Now, coming back to what has happened in these cases. So what we are hypothesizing is proliferation of resident corneal stromal stem cells is probably induced by the conducive milieu that was provided from the limbal corneal stromal stem cells or the mesenchymal cell. Another possibility is that the corneal stromal stem cells present in the limbal chips themselves migrated to the area of the scar. So some of the things that are unknown and which scientists could probably look into further are what are the factors that prevent resident corneal stromal cells in not participating in wound remodeling after stromal scarring. So why are they not doing it? And how does actual homing of limbal corneal stromal stem cells into such areas occur in these cases that we have performed? Now, again, I know that there are other groups working on these answers. That what about other sources of mesenchymal stem cells, such as umbilical cord derived cells or bone marrow derived mesenchymal cells? Could those be actually used for treatment of such scars? We wait for the answers. Second part of my talk today is on keratolimbal allograft. Now, many a times in the clinic we are faced with dire situations. For example, this is a 65-year-old patient. He presented to me with a bilateral Murun's ulcer which was progressing rapidly. Despite systemic immunosuppression in this diabetic, remission could not be achieved. Therefore, we did cyanoacrylate glue, conjunctival resection, and bandage contact lens application. Now, seemingly because of his age and we thought that this maneuver itself would be sufficient. But 1 month after application of glue, you can see that in the left eye there is still an active area and progressive melting. Now the only area that of the conjunctiva or the limbus actually that is remaining is this superior. Now, what do we do in this case? So we resorted to a procedure that has been very commonly used in Japan called the Keratolimbal Allograft technique. So in this technique, what we are doing is utilizing the limbal area of an allograft along with the corneal stroma. So we fashioned this into bits that correspond to the areas of deficiency in this Murun's ulcer and placed the lenticules at the areas. 4 months post keratolimbal allograft, and you can see the left eye has recovered beautifully with a very stable surface. Second case in which we utilized this technique was in a case of gelatinous droplet keratopathy. This patient, a young man, 37-year-old, with bilateral gelatinous dystrophy. Right eye he had already undergone a transplantation elsewhere. This transplant had failed. Moreover, the patient suffered from severe photophobia due to the presence of these gelatinous droplets. What we did then was a large graft, sutured it, harvested Keratolimbal Allografts, placed them at the limbus, placed them a little far away from the limbus, fixed them with the use of glue and a few interrupted sutures, and then 6 months down the line, he is now asymptomatic. Visual acuity has improved to 6/36. Patient is happily opening his eyes even in sunlight, and the gelatin has not yet recovered. So more about the science of Keratolimbal allografts in the next session. What I haven't spoken about today is that any type of transplantation of allogenic material, say corneal transplants, keratolimbal allografts, necessitate immunosuppression of some kind. So typically in corneal grafts, what we are using is topical immunosuppression. However, interestingly, the most common cause of graft failure is graft rejection. So are we doing enough? Are we knowing enough? Is there enough evidence? Let's find out in the next episode, in my final and third episode for Oculus Regenerus Eye Care and Research Center. Thank you very much and see you again.